Well, let's move on then, if we may, to item 13, which is the new review of congenital heart disease. And I would like to invite Bill, please, to introduce the paper.
Thanks, Malcolm. I just want to start by making what may sound like a very, very obvious point, but one that at times I think can become obscured, that this is all about people with congenital heart disease, some very young babies born with heart problems, and our collective responsibility to secure the services for them, not just now, but for when they grow as adults, and indeed for children to come. There are times when you see some of the debate over the past that you might think this is simply a kind of competition between different locations, and I think if we allowed ourselves to slip into that sort of thinking, we'd be doing a serious disservice to people who depend upon these services in this country. This is about those people, their needs, and their continuing needs now and into the future. The context for how this has come to the board is set out in the paper. It's a fairly long story, and it's a story of the safe and sustainable process, which was run under the previous health system through a joint national committee of primary care trusts with the intention of securing better services for, at that time, children, babies with congenital heart problems. The process took 4 years. It was a very intensive process, but it was challenged in two ways: one through the courts in judicial review, and also through a scrutiny committee referral to Secretary of State, who asked for the independent review panel IRP advice. Now, both of these challenges, when they played out, did identify flaws in that process, and last month Secretary of State accepted that the proposals could not go ahead as planned, asked NHS England, we are now the successor to that joint committee of PCTs, to take the process forward and to take it forward in the light of the IRP recommendations. So that's why we're discussing it here today. I just want to make a few observations about the context before we talk a little bit about the process. I think the first really important point is neither the judicial review process nor indeed the independent review panel at all questioned the need for change in these services. So they supported the aspiration to improve outcomes, improve the sustainability of safe services into the future, and recognised that there was some important work that had been done with that aim. Second point I'd say is many of the clinicians and patient groups that we've managed to speak to since we took on the responsibility have been involved in this for many years, and they're living this, and they're eating and drinking this all the time, and I think understandably they are now questioning the passion with which we would want to take this process forward. So there are some questions that we'll need to address about our determination to improve outcomes, create absolutely excellent services in future, given a lot of the difficulties that were had with the previous process. I've heard suggestions, again from those meetings over the past weeks, that one of the consequences of the review findings has been weaker relationships between some of the units currently providing services. And again, I may ask Bruce to comment on this when I finish the introduction, but it feels to me that that's quite a dangerous thing. This is a service which I think depends upon the leading clinicians working together, communicating and cooperating really well, and we need to make sure that in taking this forward we're trying to strengthen that collaboration in the interests of patients, and certainly not doing anything which would weaken or exacerbate problems that I think are there now following the current process. The most hopeful thing that I can share with you is whoever I've spoken to, whether they have felt, partially done by, either through the process or through the findings of the reviews, without exception, I've met people with an absolute passion to improve care and improve the quality of care for patients. Not just now, but what's really remarkable is these are people who've lived with these services for a long time and feel almost a generational responsibility to be part of securing even better, even more excellent services in years to come. So there is that passion there, as well as, if you like, a question mark over our ability to really drive ahead. So that's the context, I think, the environment that I've picked up from the discussions I've had so far. As I said, the safe and sustainable process took 4 years, and I don't believe we've got that time. The paper here talks about the governance arrangements that we've proposed, including the committee that, Chairman, you're chairing, and we've met once, and at that meeting it was very clear there's a determination to come back within 12 months with a plan that we can implement for improvement and change, and that's what's reflected in this paper. I'm quite sure in the discussions I've had so far that we need to talk much more about a national service. So this is not a service with very many clinicians. It's not a huge service in terms of the demand. It should be a service that we see as one serving the whole population, and I think that should be the case in the standards we would expect everywhere, and the collaboration and the cooperation we expect everywhere. And again, that message about a national service in the public interest is one that so far has had a strong response from clinicians. In the paper itself, we set out at paragraph 21 a set of principles which we propose to underpin the approach we want to take forward, as well as setting out in paragraph 23 the governance arrangements which will enable us to make decisions. I spoke to a number of the patient groups just the day before yesterday, and one of the points they were making is try not, if you can avoid it, to keep all the decisions to the end. And I think that's a very good pointer for us. If we find spaces of agreement, whether it's over standards, whether it's over how networks and collaboration should work, we should take the opportunity to capture those, because I think that will help improve services as we go along. So that's another principle that I perhaps suggest we supplement the paper with. And my final message of introduction, I think, is to have a degree of confidence. I do know people are worried about this. I do know they feel hard done by, but I think we need to display the confidence and the determination to bring about the right thing for patients. And in that discussion we were having yesterday about specialised commissioning and how becoming a national organisation and a national commissioner is perhaps enabling us to break through some of the difficulties that previously have been experienced. I'd say this might be a first opportunity to put that into practice in albeit a controversial area, nevertheless one that's extremely important for patients and families. I don't know if Bruce wanted to add to that.
Thank you, Chair. I'd quite like to come at it from a slightly different perspective. Because some people have asked, why do we spend quite so much time focusing on something which is really a very small specialty? It's only about 10% of heart surgery in general, which itself is only a tiny proportion of NHS work. But I think it's a small and really important specialty because, firstly, there's nothing more precious than your child. And secondly, there are no more vulnerable people in our society than these children who, if they get good surgery, can live a successful and fulfilling life. And one of the problems is that nowhere do we see such a complex mix of science, technology, surgical skill, ethics, and human emotion come together than in this specialty. And against that background, the nature of the surgery is changing. So it's quite clear now that the sooner you do many of these operations, which used to be done when children were of a reasonable size, the sooner you can do them, the better the results you get. So these operations are being conducted on babies now who are much smaller. Their hearts are really tiny. It requires huge technical skill to be able to do it, with great emotional demands on those doing the operations, those looking after the children afterwards. I'm a heart surgeon, as you know, by background. I couldn't do this technically. It's really complicated, and the emotional side is really demanding. And furthermore, there's very complex intensive care management involved in the recovery of children after these complicated operations. And for such a small specialty, there's quite a vast array of operations done in different combinations, something of the order of 150. And quite frankly, not all surgeons are equally skilled at doing each and every one of those operations. But all the surgeons in the country need to do enough of some sort of operation to keep their hands in. And as though that's not enough, both professional and parental expectations of a good result are growing, and that poses quite a significant demand on the services. So what we have to focus on, and I'm quite clear about this, is we have to focus on getting the best outcomes for these babies, because if you don't get the best outcome, it doesn't just ruin things for the baby, it ruins things for the whole family, and that's really, in my view, really, really important. So if we want to get the best outcomes, then we have to have an unequivocal ambition to develop what I think could be the best children's heart surgery service in the world. I think that is within our grasp. And the trouble is that because of the complex mix in all of this, that the closer we get to some of the changes, personal and professional interests, and people have heard me say this before, and occasionally political interests, conspire to perpetuate the status quo and inhibit the pursuit of excellence for these really small and vulnerable kids. So I don't want to lose the ambition, and I'm sure none of us want to lose the ambition for this service. Not just because I think it'll be really good for our health service and really good for the specialty, but most importantly because it'll be really good for the kids that are treated. But the trouble is, as Bill said, for many people this has ground on for so long that they're feeling utterly dispirited and disheartened, and the atmosphere at times has become quite toxic. And we have to try and get back to an even playing field without losing much of the good stuff that's been done, and also being sure that our evidence base for change is absolutely appropriate. So I think there are people out there who are still up for this ambition, but we owe it to them to come to a solution much quicker than we've tried to in the past, as Bill alluded to. So we need further debate with colleagues, and we really need that debate on how we get there, because much of the the disheartenment, if you like, that people feel has come from they just haven't felt the process has been right. They haven't felt that it's been tackled in the right way. So we need to get agreement on that, I think, fairly soon. I think that's all I'd like to say, Chair.
Thank you very much, Bruce. And you remind us why we're here. It's the patient. It's doing the very best for the patient. And I think the suggestion that came through in Bill's introduction about a national service which is able to ensure the highest quality of treatment, and your points about the multiplicity of operations and the inability of any surgeon to be at the top of the world on more than a limited number is absolutely critical. So may I invite any further comments as to the paper and the objectives of the next phase of the review and the process that we propose to undertake? No, I think generally people are warmly behind this bill. Thank you very much. Let me then turn, please, to item 14. Bill, I'm afraid it's you again on handling major projects.
Thank you, Chairman. And this is the independent report that the board commissioned to ensure that we can learn the lessons for handling major projects, drawing from the experience of the introduction of NHS 111, which, as the board knows, we took responsibility for from the 1st of April, but which had a history which stretched back. So while the review has concentrated on lessons we can learn, it has, of course, gone back further than just the lifetime of NHS England. Very grateful to Peter Garland, who conducted the review for us. Peter was a regional director of the NHS in the North a number of years ago, but has retired and was completely independent and insisted upon being completely independent in drawing together these lessons. And I think there are some clear messages going forward, and they're set out in summary in paragraph 4. I won't go through them, Chairman, other than to reassure you that the proposed actions in paragraph 5 for NHS England going forward are intended to address them, and they are about the professionalism of our due diligence when we're commissioning very significant contracts and projects like this. They're about the granularity of understanding the risks, and then the ability to raise those risks to the right place swiftly and with confidence that they'll be heard and acted upon. I think they're importantly about senior oversight, and indeed we're recommending that we have a major projects oversight group as part of the way we oversee risks for the organisation. And I think quite a significant message here is the importance of piloting and evaluation. So where you can, with a very significant large-scale project, we should be trying to introduce through almost piloting and evaluating as you go along. The importance of evaluation, which connects absolutely to our values about being evidence-based and rigorous, I think is a very important one. We have had a first sight of which sort of projects going forward should be caught by this. Now, I know we've suggested for a starter 3, first NHS 111. I know Barbara may want to comment at some point on what's already being done there. The transition of the Family Health Service to the administration service for primary care, which we're committed to doing in our business plan, and also our interface with customers through the customer service platform and the contact centre, where we think there's opportunity to do an awful lot better into the future than we've achieved in the past in the NHS, but which will be a major undertaking. There will be others, and I'd suggest that on the back of this we share with colleagues a list of potential major projects and perhaps invite has certainly Ed in his audit committee role to cast an eye on some of that. So the recommendation is to receive the report and to consider the action plan proposed.
Thank you. I might invite Ed
Peter Garland's report, I think, for the avoidance of doubt, is Peter Garland's report and is made public because that's our commitment. And he was very rigorous in his review. I mean, sporting metaphor, in a way, there was a bit of a hospital pass somewhere in this, and the second hospital pass to Barbara, who picked it up on the 1st of April, has done a splendid job in managing the system to stability. None of this is rocket science. This is the real difficulty with this. When you see these reports, you go, but yes, this is obvious. The key thing to me is that we create institutional learning from this incident, which I think we're absolutely committed to do, that we create the governance and we create the capacity to get these things done, and we don't rush at them. The end-to-end cost of rectifying something that goes at speed without sufficient thought and without sufficient testing is significantly higher, and there's so much evidence on that, than the end-to-end cost of getting it right by staging it and working through it in a proper programme project management way with appropriate oversight. And I think if there's one great thing that comes out of this for us is how to do these with those key major projects that we have in the future.
Yes, and just to reassure the board that immediately at the end of March, most of these recommendations are put in place. Certainly, initially I think it was about serious attention being given to this by our senior managers and senior clinicians across the country in terms of supporting CCGs. So our regions and areas have done a sterling job on that. It was about securing additional resource in the National Support Centre dedicated to this, but most of all I think putting in place a programme oversight group with proper rigorous programme management assurance and risk mitigation processes, and as I say, that programme oversight group meets regularly, and in accordance with our assurance and risk processes, a review of what's going on in 111 is frequently taken to the executive team, who talk about this, and similarly to the board. Another couple of areas which reflect what's in the report as well as, I mean, it suggests flexibility on time, and I reported earlier that we were flexible on the rollout of 111 in a couple of areas. But also in terms of assurance and checks, we are expecting any new provider of 111 to undertake due diligence and share this with us. But we're also ensuring that we have a full external assurance process available to our CCGs to look at any new providers. So that'll be a dual process. And finally, in terms of procurement, Tim and I are ensuring that we find a way to have a national procurement expertise which can support CCGs when they undertake any of these similar procurements.
Good. Thank you very much. Yes, Joe.
I think it's really helpful that this comes so early in our existence, and I'd just like to suggest maybe Bill and I pick up an action, which is to do some systematic staff briefing with the staff involved in some of the projects we've already identified, but then maybe identifying some training needs falling out of that we can roll out across the organisation.
And I do think the issue about, going back to the conversation we had about the mandate, is this issue about accountability.
Yeah.
Who's accountable for what is really important for this? So part of the issue here was the department, ourselves and CCGs. There are other examples, proton beam therapy and others, where the department and ourselves, this forces you to get that clarity of accountability, and where you get it confused, that's where we get problems, I think.
Yep.
No, I thank you, and I agree with all of that. I think the critical thing is that when something goes wrong, we don't overlook it or cover it up. Actually, we get on and find out what went wrong, and we learn from it. And I'm really pleased. I thought that this report was clear. It has enormous opportunities for learning. It's not a blame-casting report. We're not into that game. Our whole future depends upon our understanding properly how we conduct major projects for the future and how we learn from each one that we do. I'm very grateful to you, Ed, for initiating with Bill and with Paul the review that's been undertaken.
Just one point, if I may. In your paper, Bill, paragraph 9, I find is a bit too passive about reporting to the board. So it says where there are areas of risk that need to be highlighted to the board, these can be escalated. I would put it in a more positive tone. So if you go back to the 111 experience, one of the things I would say is that the board had no visibility on this being a looming problem, and I think we should put a higher onus of reporting to the board.
You're happy with that?
Yeah.
Good. Okay. Thanks very much. Thank you very much for the report.